Good morning, one and all. We are about to start our instruction course in Keratoconus. Keratoconus, a bilateral asymmetric disease which results in progressive thinning and steepening of cornea leading to irregular astigmatism and profound visual morbidity. With increasing public awareness, more and more patients are approaching the general ophthalmologist. With the newer diagnostic tools, early detection of the disease is also possible, which can help in arrest of the disease and a better visual rehabilitation. Some of these modalities could be made available at the disposal of early care specialists, including government level setups, so that more and more patients can avail the management at their primary and secondary level. At the same time, they should be aware of the modern and advanced technologies of management so that timely reference to a specialist in the field is made possible. The purpose of this instruction course is the same. I would like to invite the first speaker to talk about epidemiology and diagnosis of keratoconus, what you should not miss. Dr. Nimmi J. from Government Medical College, Thrissur.
Good morning all. Today I am going to speak on the topic epidemiology and diagnosis of keratoconus, what you should not miss. First of all, keratoconus is defined as a bilateral and asymmetric progressive corneal ectasia with the onset typically during the second decade of life. There has been numerous epidemiological studies to identify the incidence and prevalence of keratoconus. One of the first was by the Kennedy et al. In Minnesota, USA, and it found a prevalence of 0.054%. This was similar to the studies in Russia and Macedonia. In a study conducted by Jonas et al. In Maharashtra, India, identified a prevalence of 2.3%. A study in China found out a prevalence of 1%, and the highest recorded prevalence was by Toros Neto et al. In Riyadh, Saudi Arabia, and it showed a prevalence of 4.79%. So it is clear that there is a higher prevalence of keratoconus in Asia, especially Middle East Asia and Oceania. A recent meta-analysis was conducted among 50 million people from 15 countries, and they have found a global prevalence of 138 in 1 lakh. Now regarding the risk factors for keratoconus, as you know, the onset of keratoconus is in the late teens or in the early 20s, but modern technology has led to earlier diagnosis. It is a progressive disease and progression is seen up to 35 years of age, and it is higher in children than in adults. These are the transmission electron microscopy images of the corneal collagen bundles seen in the young and the old persons. With aging, the interfibrillar distance decreases and the collagen bundles become thicker. This in turn results in increased corneal rigidity, and thus the severity of keratoconus decreases with age. Many studies have been conducted to identify the gender preponderance. Some have shown a more of female preponderance, some more of male preponderance. The collaborative longitudinal evaluation of keratoconus CLEC study has reported a more functional discomfort in women. A recent discovery is that androgen, estrogen and progesterone receptors are present in the corneal epithelial and the stromal cells. And because of the hormonal fluctuations, the onset of keratoconus is seen towards puberty. Another time of hormonal fluctuations is the pregnancy, when there is an increase in level of the serum matrix metalloproteinase and a decrease in the tissue inhibitor of metalloproteinase, and this causes progressive corneal thinning and there is a progression of keratoconus. Keratoconus is a familial disease and the pattern is an autosomal dominant pattern, and CLEC study has shown a positive family history in 13.5% of the patients. The higher prevalence is seen in the Middle East countries because of the hot and dry climate for most parts of the year. So there is an excessive sun exposure, excessive exposure to ultraviolet light, and this results in the oxidative damage resulting in keratoconus. Frequent eye rubbing is an important preventable factor, and Clegg study has reported that 48% of the keratoconus patients rub both the eyes vigorously, while 2.2% rubbed only one eye. And the cases are of asymmetric keratoconus, in which the most affected eye was the one that was rubbed most vigorously. The mechanism of eye rubbing is that eye rubbing causes microtrauma to the ocular surface. This causes the epithelial and stromal cells to secrete MMP1, MMP13, and there is a release of interleukin 1, 6 and TNF alpha. This results in the apoptosis of keratocytes, which results in the progressive loss of stromal collagen and thus results in the corneal thinning. These are the systemic associations of keratoconus, which include Down syndrome, mitral valve prolapse, connective tissue disorders like Ehlers-Danlos syndrome, Marfan syndrome, osteogenesis imperfecta. Now, taking history in a patient with keratoconus, the most important history is the frequent change in glass prescription. That is, there is a refractive instability. There is also associated allergic eye diseases like VKC, eye rubbing, systemic atopy. And family history is also important to identify formiferous keratoconus or keratoconus suspect. Other symptoms include seeing ghost images, difficulty in looking towards light, eye strain, halos, etc. On examination, the best corrected visual acuity is reduced and it may not be improved with manifest refraction, and the spectacle or the contact lens acuity may not match the pinhole acuity. It is due to the corneal irregularities. There is high myopia and also irregular astigmatism. This is the Amsler-Krumage classification, grading keratoconus into 4 stages, stage 1, 2, 3, 4, based upon the mean central keratometry value less than 48, less than 53, 53 to 55 and more than 55. It also takes into account the central corneal thickness, spherical equivalent and presence or absence of central corneal scars. The more recent classification is the ABCD system of classification. A is the anterior radius of curvature, B the posterior radius of curvature, both in the 3 mm zone centered on the thinnest location on cornea. C is the thinnest pachymetry value, and D the distance best corrected visual acuity. Now, just brushing upon the clinical signs of keratoconus, it may be early and late signs. Early signs are the scissoring reflex, oil droplet reflex, Risuti sign, corneal thinning and the prominent corneal nerves. Late signs include Fleischer ring, Munson sign, Vogt striae and the corneal scarring. This is a video demonstrating the scissoring reflex. It is a very early sign of keratoconus and it is seen while doing retinoscopy. Next is the oil droplet reflex or the Charley sign. It is an annular dark shadow reflex that is observed while performing distant direct ophthalmoscopy. Next is the Risuti sign. When a torchlight is shown from the temporal aspect, we can see a conical reflection on the nasal aspect of cornea. This is one of our patients showing this clinical photograph. There is a central paracentral corneal thinning, and the thinning is maximum at the apex of the cone. Another early feature is the prominent corneal nerves. This is a Fleischer's ring, which is a late sign. There is a brownish deposition of iron in the basal epithelial cells and in the base of the cone, and it is best appreciated with the cobalt blue light. This is the Vogt striae, which is the deep stromal stress lines, which is seen in the posterior stroma, and as you can see in this video, this disappears on applying gentle pressure on the globe. Munson sign, this is also one of our patients. When the patient looks downwards, you can see a protrusion of the lower eyelid. This is a late sign. Then corneal scarring occurs when there is a rupture or break in the Descemet's membrane. Another important thing is the acute hydrops. When there is a break in the Descemet's membrane, there is leakage of aqueous and this leads to stromal edema. This acute hydrops is seen in 3% of patients with keratoconus. The patient presents with sudden onset decrease in vision, photophobia and pain. And the problem is that mostly it goes in for corneal scarring and the treatment goes in for keratoplasty. This is subclinical keratoconus. In the 50% of the clinically normal fellow eyes of patients with unilateral keratoconus have got subclinical keratoconus. They progress into keratoconus. So this is identified by using the newer imaging technologies like corneal topography and corneal tomography, and it will be dealt by Dr. Ashwati in the next session. So the take-home message is that the keratoconus prevalence is very high in our country, in India, and frequent eye rubbing is an avoidable risk factor. And always suspect keratoconus when there is any refractive instability, like frequent changes of glasses, when there is history of any allergic eye diseases or family history, and carefully look for the early signs, and never miss out the late signs like Fleischer's ring, Munson sign, and Vogt striae. And early diagnosis and treatment helps to prevent progression and also going in for complications like acute eye drops. Thank you all.
Thank you, Dr. Nimi, for that very excellent presentation. With that introduction, we will go on to the next topic, that is topography and tomography interpretation. What you should not know. You should know in keratoconus by Dr. Ashwati. She is also from Government Medical College, Thrissur.
Good morning, all. Even with a very careful physical examination, sometimes you might miss the early signs of keratoconus. It is then that topography and tomography play an important role. So what is basically the difference between topography and tomography? Topography is basically the surface characteristics, the surface curvature and the details. But tomography is more of a 3D reconstruction where many things other than in addition to the anterior curvature can be studied. So we have basically three techniques: the placido disc based, which is what we call as topography, then slit scanning system and the Scheimpflug imaging, which come together constitute the tomography. Coming to the placido-based system, that is a video keratoscopy, a placido disc-like thing is used to reflect Myers onto the surface of the cornea, and depending on the distance between the Myers, you can assess the curvature of the cornea. When the distance between the rings are greater, the cornea appears to be flatter, and when it is lesser, that part of the cornea is steeper. So we also get a color-coded map from this, where the warmer colors represent a steeper cornea and the cooler colors represent a flatter cornea. Next is a scanning slit technology, which is utilized in OBSCAN. Here, around a lot of slits, maybe around 40 slits, 20 from the nasal and 20 from the temporal sides are projected onto the surface of the cornea, and on each slit, around 240 points are being analyzed. So the whole of the cornea is being analyzed this. And in the Scheimpflug imaging, the Scheimpflug technology is being used. And the advantages of this technique is that it facilitates a 3D reconstruction of the anterior segment. Therefore, in addition to the anterior curvature, we can also know about the posterior curvature, the corneal thickness, the anterior chamber depth, in addition to details about the lens also. Also, it has much greater area of coverage. The limbus to limbus area of the cornea is covered, whereas in topography, only about 40 to 60% of the cornea is being covered. And also, this is not affected by tear film abnormalities, unlike in topography. So this is what we get, report of the pentacam. In the first part, we have the patient details. The patient details we have to enter correctly, especially the year of birth. The age of the patient is very important in comparing with the data. Next thing we have to look at is the quality specification or QS value. If it is given okay, then the scan is fine. But if any of the other data is displayed, data fix or model, then you might have to repeat the scan. Below that is the Q value, which represents a measure of the corneal sphericity. And in normal cornea, the value is between 0 to -1. If the cornea becomes hyperprolate, as in case of a keratoconus, the value becomes more negative. Next is the keratometry values that are depicted. If the keratometry Kmax value goes above 47 diopters, you have to be suspicious of an ectasia. Next, we have the quad map that consists of 4 maps. One is the anterior sagittal curvature, which is similar to the topography image that we get. Then there is the anterior elevation, posterior elevation, and corneal thickness maps. Coming to the axillar curvature map, here, in addition to the curvature of the anterior corneal surface, which is represented as diopters at each point, we also can identify certain shapes. These shapes can be either symmetrical, round, like the round, oval, or symmetric bow tie, which is usually normal, but when the Kmax exceeds 47 diopters, you have to suspect an ectasia. Asymmetric shapes are there, like the superior steepening, inferior steepening, or asymmetric bow tie with superior or inferior steepening. When the difference between the inferior and superior part is more than 1.5 diopters, you can suspect an ectasia. There are skew deviations. When the skew is more than or equal to 22 degrees, then also you have to suspect an ectasia. Special shapes are almost always abnormal, like the butterfly, crab claw shape, and irregular. So these are the high risk and moderate risk characteristics which can be ascertained from a topography map, anterior curvature map. Next is a pachymetry map. In this, there are two things you have to look for. One is the thinnest location, the thickness at that region, and the location of the thinnest point. If the thickness is less than 470 microns and if it is inferiorly displaced, the thinnest location is inferiorly displaced for more than 0.5, then you have to suspect an ectasia. Next we move on to elevation maps. This is called anterior float or posterior float. Now to get an elevation map, you have to compare the cornea to a reference surface. Now if the reference surface is a planar surface, then even mild, advanced and normal corneas look similar. So in that case, we have to take a reference surface which as closely approximates the normal cornea as possible. So after much of deliberations, a best fit sphere from the central 8 mm optical zone has become the standard reference surface. So these are the characteristics we have to look for in an elevation map. If the anterior surface is elevated for more than 15 microns and if the posterior surface is elevated more than 20 microns, you have to suspect an ectasia. But a problem is there, these elevation maps, these reference surfaces are derived from the anterior curvature map. But if it is an ectatic cornea, then that causes steepening of the reference surface. So a part of the cone will be masked. So to circumvent this problem, we have come up with enhanced reference surface which excludes a small zone of 3 to 4 mm surrounding the thinnest location. So when that area is excluded, it flattens reference surface and allows the ectatic region to become more prominent. So this is in comparison, the cornea in comparison to the best fit sphere and the enhanced reference surface. This again, it is more prominent with the enhanced reference surfaces being used. Now this brings us to the Bellin-Ambrosio enhanced ectasia display, which is a comprehensive refractor screening display incorporating both the enhanced reference surface and pachymetric progression graph. Now in this image, you can see that the upper two ones are with reference to the best fit sphere. The middle two images are in reference to the enhanced reference surface, and the lower two images is the difference map. That is the difference between the elevation map using an enhanced reference surface and a best fit sphere, and the difference are very much enlightened here. When the difference between the two is more than 7 micron, it is presented in red. When it is between 5 to 7 microns, it is yellow, and less than 5 microns, it is represented in green. You also have a corneal thickness map represented here and a corneal spatial profile here. Thickness spatial profile. There are 3 lines here which represent, this is the normal and this is 2 standard deviations above and below. When this cornea, the values of this cornea grows through the center, then everything is okay. When it approaches either of these lines, or when this slope goes too much abnormal, then that is a cause for concern. We also have various D values represented in the bottom part, where when this is represented in white color, then it's fine. If it is yellow, it's a cause for concern, and if it's red, then it's almost definitely abnormal. ABCD classification is described already, and ABCD classification is also represented graphically in the map, and you can ascertain the staging of the keratoconus from this. And we also have a Bellin ABCD progression display here, which is used to determine the ectatic progression, and up to 8 examinations over time can be displayed using this graph. Now here you can, all the 4 parameters A, B, C and D are represented here, and you have 2 type of gates, the green gates used for early disease and red gates for established keratoconus cases. When these value reaches these grades, then you have to be concerned and it is time to take up the patient for treatment. Thank you.
Thank you, Dr. Ashwati, for the excellent presentation. Next, I invite Dr. Malika for the session, Collagen Cross-Linking and Contact Lens in Keratoconus, our experience in Government Medical College setup.
Good morning, one and all. Today we have very advanced technology to deal with most of the situation. But sometimes still A hammer can do wonders. Sometimes the most ordinary things could be made extraordinary simply by doing them with the right people. I emphasize on the right people. Choosing of people is very important. That is what I am going to present today, collagen cross-linking and contact lens practice in keratoconus, our experience in medical college setup. Collagen cross-linking using ultraviolet light and photosensitizer riboflavin was developed to treat the corneal thinning and ectasia by increasing the biochemical strength of the cornea. A significant increase of 328.9% in the biomechanical rigidity of human corneas has been documented after collagen cross-linking. Treatment modality for the progressive keratoconus at all stages we all know, and it stabilizes the progression of disease, and it has got an excellent safety profile proven in adults. I would salute this genius, Dr. Theo Saylor and his colleagues in Dresden University, who developed this therapy which has revolutionized the treatment for keratoconus. If you look up the history of keratoconus, surgical procedures done for the keratoconus over 30 years, you can see this is very evident. So we started doing topography around 2015, 2016, and we purchased the CLUVR Rapid in 2016 and started doing C3R. I am very thankful to my previous HODs and also to Dr. Late Krishnankuti, from whom I learned the basic techniques of contact lens fitting. When I started the technique, so many concerns for me, like what will be the acceptability? What about the availability of riboflavin? What will be the cost? And then I set up all the protocols. I was very meticulous in patient selection, assessment criteria, and very meticulous in monitoring and follow-up of the patient. It was in the beginning, I was doing 3 cases with 1 vial of ribocross. That is because of not very speedy availability of the riboflavin. So from the year 2018, we are doing the cases. During the COVID period, we had a regression. Otherwise, we are regularly doing the cases. We started documenting systematically since 2018. And we did a study to analyze the outcome of corneal collagen cross-linking with ultraviolet A and riboflavin in arresting the progression of keratoconus based on the changes in the corneal topographic parameters, refraction and visual acuity, and also to study the safety of treatment modality. We included 78 eyes of patients with keratoconus with documented progression, that is change of keratometry value of more than 1 diopter over 1 year, or change in astigmatism of more than 0.5 diopters over 1 year. We excluded patients with corneal thickness of less than 400 micrometers, severe corneal scarring, severe dry eye, and pregnant women. And the parameters we assessed before taking the patient for treatment, we recorded the visual acuity, best corrected visual acuity before the treatment, and uncorrected visual acuity, refraction, and corneal topography parameters. This is the machine we have. This is a very ordinary and very basic machine. Only these axial elevation, tangential refractive maps you can have. Only values for comparison is the SIMK value and the KISA index. SIMK is the simulated keratometry in the maximum power of the surface along any axis and the power orthogonal to the axis. KISA percentage index is the product of central K reading, IS value, astigmatism measured by SIMK value, and skewed radial axis index. We know that it is a very effective index. KISA percentage is a very effective index in the identification of keratoconus, but may have a significant number of false negatives in the clinical diagnosis and its incipient keratoconus cases, which can suppose a major risk in its use as a screening tool in refractive surgery. But I didn't have any option. The procedure was performed in operating room under sterile precautions. We did we practiced epithelium off technique. And after a thorough wash of the corneal surface, 0.1% riboflavin was applied for 30 minutes at 5 minutes interval. Ultraviolet A irradiation 365 nanometer for 30 minutes was then performed with 50 millimeter distance from the cornea with an irradiance of 3 millivolts per centimeter squared. Riboflavin installation was continued at 5 minutes interval throughout the process of UVA irradiation. After completion of irradiation procedure, thorough wash was again given, followed by the application of a soft bandage contact lens and antibiotic eye drops. On the third day, BCL will be removed, ensuring complete epithelial regrowth. Topical antibiotic and steroid drops were applied for 3 weeks and a preservative-free artificial eye drops for the 6 months. The patients were instructed to avoid driving for 2 weeks. The patients were followed up at 1 week, 1 month, and 3 month and 6 month intervals respectively with the same visual and topographic parameters, each time warning against eye rubbing being reinforced. Visual rehabilitation was done either with glasses or RGB contact lenses or special contact lenses, for which I used to refer patients to specialists. These are our study results. Age distribution. Youngest age group we did was 11 years and the oldest age group 35 years. The mean SIMK before C3R reduced after 6 months of C3R, p-value less than 0.01, which is statistically significant. The mean KISA percentage before C3R reduced by 6 months after the procedure. This is the comparison of KISA percentage value at different time intervals. And we found that there was a statistically significant reduction in KISA percentage index and simulated K values in patients with progressive keratoconus 6 months following C3R. And this is, in our study, 36.4% participants had complications at first week, that too minimal corneal haze, which resolved within 2 weeks. None of them had any complications in the first month, third month, or 6 month time intervals. So we prescribed spectacles for 44 patients, RGP lens for 12 patients, special contact lens for 4 patients, none for 11, because they are using none, because they are happy with whatever vision they have. And we lost follow-up for 7 patients. So to conclude, early detection of keratoconus and prevention of its progression can be aimed at primary level. Even with basic corneal mapping, refraction, keratometry, and pachymetry, progression of keratoconus can be monitored. C3R is the gold standard and easy and safe procedure for arresting the progression and could be performed at secondary level. Most of the early and lower grades of keratoconus could be managed with spectacles and simple locally available contact lenses. Patient education about importance of regular follow-up, avoiding eye rubbing, managing allergies to prevent progression is very important. Having said this, and yes, well, it seems to be a very simple, but a step behind the most advanced technology. That is why I am emphasizing that you should keep in touch with the specialist with your premises so that you can refer the patient at any time. Thank you so much.
Thank you, madam, for that wonderful talk. Next, I invite Dr. Anita Jabbar to share her insights on the optimal management of keratoconus, challenges and solutions.
Good morning. I thank Mallika and KSOS for this opportunity. And after 3 beautiful talks by 3 beautiful colleagues, so I am taking you a little step forward. So whatever I am telling, I don't have personal experience, but we should know what is happening in the field of keratoconus, because in the last 2 decades, there is a paradigm shift in the management and diagnosis as well as treatment of keratoconus. So there are management expansions. Whatever we are heard are what we can do in our setup, but there is something else happening elsewhere. So this is called a stromal. These are all examples. Many more are happening, and I am giving you three or four examples of further steps, like stromal regeneration. We all know that keratoconus affects 85% of the corneal stroma and the Bowman's layer. So it can be rehabilitated by minimally invasive procedures. Other than your PK or DALC, it can be rehabilitated by minimally invasive procedures that effectively regenerate the corneal stroma. How is it possible? It is possible by the corneal stromal stem cell therapy. This can be done in advanced keratoconus. So how they are doing is autologous mesenchymal stem cells in the form of suspensions containing the quiescent autologous adipose derived adult stem cells are obtained by elective liposuction, and these are transplanted into a mid-stroma by the femtosecond assisted lamellar pocket in the patients with advanced stage 4 keratoconus, so that stromal regeneration is happening. And this adipose tissue derived adult stem cells were capable of surviving in vivo, showing a perfect biointegration without any clinical inflammatory response or rejection, generating new collagen production within the corneal stroma. This is the example they are showing, this anterior ASOCT picture. You can see, can you appreciate this? This is a hyperreflective line in which the stem cells, that lamellar pocket and the stromal regeneration is happening. And after 12 months or 1 year follow-up, you can see the stroma has thickened, and this line has also broadened. So it has nicely biointegrated into the stromal tissue. Another procedure is the stromal keratophakia, that is xenogenic using animal products. This is an innovative xenogenic stromal keratophakia technique using a bioengineered cell-free porcine construct, which is double cross-linked. The porcine construct is made up of medical grade type 1 porcine dermal collagen to mimic the human corneal stroma with abundant type 1 collagen, and it is double crossed to improve the strength and stability of the implantable hydrogel. So this hydrogel is implanted using femtosecond pockets, and the stromal keratophakia is done for the stromal stiffening. Then gene therapy is also happening. The recent advent of next generation sequencing has significantly advanced the ability to accurately sequence any genome of interest with reduced time of cost. These are the genes, genetic mutations that is happening, examples of genetic mutations happening in the keratoconus patients. And also everywhere else, artificial intelligence also has a major role, as corneal tomography and ASOCT are the two most common modalities used in screening and diagnosing keratoconus. These images are most commonly used to train and develop the AI algorithms for keratoconus. And AI has also shown to be able to efficiently predict the local progression of the keratoconus. And coming out to our day-to-day practices, these are the challenges we sometimes come across. Sometimes a pregnant lady will come, and I have burned my fingers because without knowing that she was pregnant, CXL was done many years before, and finally she was an NRI patient, and after many years she came to me with a central stromal thinning. But she was happy because she was having 6/9 vision as a pinhole effect, but I was scared seeing her cornea. So proper history is important. And how do we tackle pediatric keratoconus? That is also important. And also finally I will tell you the CXL in thin corneas. In pregnancy, as Dr. Nimmi was telling, there is increased estrogen and progesterone, thereby weakening the collagen, leading to progression of the disease. And also there will be slight transient corneal edema, and they will have discomfort while wearing contact lenses due to the dry eyes and changes in the corneal curvature and fluctuating refraction. So all these should be kept in mind, and avoid cross-linking. No procedure should be done in a pregnant and a feeding mother due to lack of data on the safety and potential risk to the fetus. Also, procedures like PKP or INTAX should be typically postponed after pregnancy and lactation. Even RGP and scleral lenses may need periodic refitting. And pediatric keratoconus. Pediatric keratoconus onset before 18 years of age is less common, but it is more aggressive than the adult keratoconus. There is also a genetic component because it is commonly seen in conditions like Down syndrome, Marfan syndrome, and collagen tissue diseases. And the genetic influence with familial inheritance is also observed because patients with first degree relatives with keratoconus have a 15 to 67 times higher risk of developing corneal ectasia. So what are the challenges? Because they are coming late to us, also late diagnosis, and they will progress faster. There is unsuccessful conservative care. Way back in 1959, chronic eye Ridley had described that chronic eye rubbing and atopy as a risk factor for keratoconus was described. So control of the eye rubbing behavior, which may not be possible sometimes. Accurate tomography also may not be possible, and follow-up also should be, maybe they will lose for follow-up for many years. So adult, comparing with the adult and the pediatric keratoconus, at the first diagnosis itself, it will be in a more advanced stage. Morphology of the cone also will be different from the adult because the cone will be more centrally placed and so lesser irregular astigmatism, and the pediatric patients maintain a good binocular single vision until both eyes are affected. That is why they present later, and the both eyes will be asymmetrically affected. And the patient and the parents may not be knowing because the non-dominant eye may be progressing without the patient noticing a change in their visual acuity. It is only when the dominant eye deteriorates, they become more symptomatic and they seek help. And also ocular aberrations generated by the irregular cornea may be partially compensated by the internal ocular structures and a high accommodative power present in the younger age. That is why they are presenting late to us. Highlights in pediatric cornea keratoconus management are: keratoconus in children is more prevalent and occurs at younger age in Asian countries including India. Corneal cross-linking has been found effective in arresting the progression of keratoconus in children. So corneal cross-linking should be considered without waiting. Even for the first visit, without documenting progression, you can advise cross-linking. Conventional Dresden protocol is effective in stabilizing keratoconus, but if you want to cut short the time, then accelerated cross-linking also is found to be equally effective. Transepithelial and other CXL are safer but less effective than conventional or accelerated protocols, and CXL should only be performed after treating children with active vernal keratoconjunctivitis. And complications like corneal opacity, edema, sterile infiltrates, and even microbial keratitis have been reported. Due to the rapid progression and severity, higher risk of acute corneal hydrops leading to increased corneal transplantation is more, and the tomography may not be very accurate, but high resolution OCT and the higher frequency ultrasound can detect the epithelial thickness changes, stromal, and the corneal thickness changes, which may be more sensitive in diagnosing keratoconus in the early stage. So the thing is, you have to pick them up early. And other procedures like intracorneal ring segments are not commonly used due to the aggressive nature of the disease, frequent eye rubbing, poor patient compliance, and unpredictability of the results. I have only 1 more minute. Shall I continue or? So what about treating borderline or thin pachy? When the corneal pachymetry after removing the epithelium, if it is less than 400 microns, the endothelial cytotoxicity threshold is reached. So there is a chance of endothelial burning. So newer protocols like using of the hypoosmolar riboflavin, which can swell up the cornea little bit, but due to the desiccation, due to the time, the desiccation, the swelling up will come down. So you can use an accelerated C3R with the hypoosmolar riboflavin. Also transepithelial, without removing, in thin corneas you can do a CXL without removing the epithelium, but you have to use some enhancers because the riboflavin will penetrate only when the epithelium is off. So other enhancers like dextran, EDTA, BAC, and trometamol can be used to increase the penetration of the riboflavin. Also the riboflavin is an excellent molecule for iontophoresis. So this is a process which can assist cross-linking. A negative electrode is kept on the cornea and a positive electrode is kept on the forehead, and a minimal power is generated so that the riboflavin will will be absorbed on the stroma. Also, other techniques for thin cornea are the lenticule-assisted CXL and the contact lens-assisted. The stromal lenticule removed during the SMILE procedure is placed over the cornea, and the riboflavin is soaked, and then irradiation is done. But the potential limitations of these techniques are the reduced oxygen availability for CXL, and the CXL may not be effective as your other normal procedures. Thank you.
Thank you, Dr. Anita, for that insight. And now let me invite Dr. Sujit Nayanar for the keynote address, Paradigms, Paradoxes and Controversies in Contemporary Management of Keratoconus.
A very good morning, and thank you for this opportunity. Coming to the last topic of today's IC on keratoconus, it's titled as Paradigms, Paradoxes and Controversies in Contemporary Management of Keratoconus. In this, I'll not be highlighting any specific aspect of keratoconus, but I'll be just going through the various or few among many unanswered questions in the contemporary management of keratoconus. So if you look at the publications in keratoconus, there's a huge surge in the number of publications. When you look at the first part, it's like only 1,754 publications in 100 years, that is till 1999. But in the last 24 years, there's almost 5,000 plus publications. There is one particular conference that is dedicated only for cross-linking, and it's happening for the last 20 years. There's one journal only for keratoconus. So much of research is happening in this field. And definitely there is paradigm shift in all the aspects of the keratoconus management, right from the epidemiology to the surgical management. But still, there is a lot of disagreement among the experts in all the fields of keratoconus management, and we are trying to connect the various dotted lines so that we can give the best possible treatment to the patient with the available knowledge at this time. So, are we really witnessing a true increase in the incidence of keratoconus? We don't know, because the prevalence is, when we were studying, it was 1 in 2,000. Now it has crossed 3.3% in India, and more than that in other countries like Saudi Arabia. It's probably we are picking up more cases. Slides are not fully visible. Can you change? Probably we are picking up more cases because there is a lot of demand for the refractive surgery, and we are doing a lot of refractive surgery screening. Also, there's a possibility that our lifestyle has changed. There's more of pollution, more of allergy, and we are actually making more of keratoconus patients. So, all the more we are seeing more of unilateral cases. So there were a lot of case reports coming up. There is unilateral keratoconus, but the paper on the global consensus on keratoconus has clearly stated that it's always a bilateral disease. So what you are seeing as a unilateral disease is nothing but an asymmetrical or presentation, of a bilateral disease where one eye has actually presented a little early than the other eye. So the other eye is always called a forme fruste in such cases and will be considered as a keratoconus even if there is no clinical symptoms in it. When we think of bilateral cases, we have a clue that it may be something related to the genetic. But is there other than genetic, like environmental and the racial, environmental or geographical thing that's happening? That's the clue that we are getting from the example of Saudi Arabia and other countries in the Middle East, where they have a peak of prevalence in that area. Is it due to any environmental cause? So when they studied the prevalence of keratoconus in UK, they found that still the Asians in the UK were having more keratoconus than the actual national average. So that shows there's a two-hit hypothesis where you have a genetic predisposition, and at the same time when you have an environmental thing putting on that, it actually manifests. So among the environmental thing, two main things have come up, that is the ultraviolet rays as well as the eye rubbing. I'm sorry, the orientation of slides are here and there and total slides are not coming up. The slides, it's not the way I've put it. No, previous slide please. So the highlights here is on the UV light and the eye rubbing. So UV light, it's actually a paradox. Like UV light we are using for the treatment of corneal cross-linking and for the keratoconus. So how UV light is causing problem? It's causing oxidate stress in the cornea, which in keratoconus predisposed cornea is unable to tackle. So what happens in cross-linking? Cross-linking, what happens is you have a riboflavin which acts as a photosensitizer, and you have riboflavin radicals as well as the oxygen radicals, and two types of photochemical reaction, one aerobic and non-aerobic reaction is happening. So oxygen and riboflavin radicals together are forming the cross-linking. I'll come back to. Don't look at the slide, please. So the question here is there a true association between atopy and keratoconus? We have been telling like allergy and keratoconus is so much related. But in a large series of study, it has been shown that it is not the allergy that is actually associated, it's the eye rubbing. Yes, allergy is associated, but the strength of association is more for the eye rubbing rather than the atopy itself. So if you can see something in the last part of the slide, the angioedema, urticaria, atopic dermatitis, history of anaphylaxis, these are actually not related to keratoconus. So we have been going with the idea that allergy directly proportional to keratoconus. It's not that. It is actually the eye rubbing that is causing the problem rather than the atopy itself. So we are having keratoconus in non-allergic people also. People who are having, you can, I'm very sorry about the slides, people who are having the habitual eye rubbing, they have been called in this context as chronic habitual abnormal rubbing, CHAR. These are the people whom you can very easily see, like we have a lot of people who are sitting in front of the screen the whole day. They keep doing this when the eyes are tired. They keep rubbing this, which when we ask them, are you an eye rubber? They say, no, I don't rub my eyes. This happens very involuntary and they actually don't know that they are rubbing the eyes. And these are the group of people who are non-allergics but eye rubbers, ultimately ending up in keratoconus. And the eye rubbing, is it just mechanical effect of the eye rubbing or is anything more? It is mechanical as well as inflammatory. So we have come from a non-inflammatory etiology of keratoconus to inflammatory etiology. But we are not seeing any signs of inflammation. It is called post-inflammatory. But we are looking the signs of inflammation on cornea. The signs of inflammation is not on the cornea, it's in the ocular surface and the tear film. All the disease markers or the biomarkers of the inflammation is in the tear film and not in the cornea. So again, there are certain confounding factors for that. You have allergy associated with it, you have eye rubbing associated with it, you have dry eyes in such cases. All this can cause inflammation. So we are not sure whatever biomarkers we are seeing in the tear film, is it specific for keratoconus or can we directly relate these biomarkers for keratoconus so that we can use it as a screening tool to identify early keratoconus. Another screening tool which we use is OBSCAN or topography. We normally use at the anterior and the posterior curves, but it has been identified that if you look at the comma aberrations, you can actually identify the keratoconus much early than the changes that happen in the anterior and the posterior curve. But is it anyway important that we do all these preclinical tests to identify the keratoconus? Are we going to treat a preclinical patient? That is the question. Is there any need for screening like what we do in glaucoma? If we identify it, are we going to treat it or we are going to document the progression? We very well know that every ectasia need not be cross-linked. Some of them may not progress at all. And what we say as cross-linking, a paradigm shift in the treatment has its own set of complications and failure rate also. So it cannot be given to all those who have been diagnosed as keratoconus. And we have a unwritten rule or we have a rule that we don't do anything about 35 years or in a patient who is already having 6/6. All these set of complications is very well known and it's up to in the paper publication and is around 3% of complications is already well known. But this is one new complication that is coming up in the keratoconus, like what Dr. Anita Madam told. Patients who have been aggressively cross-linked 10 years, 15 years back are now coming up with progressive thinning of the cornea. At that time, we have reported, we have all presented in the conference cross-linking safe after 1 year, 2 years, 3 years. But now after 10 years, they are coming with these sort of corneas, and these have been presenting in conferences now more and more. It's a progressive thinning of post cross-link cornea happening many years later. So what could be the cause for it? Going back to the previous slide, we have been telling that we are using oxygen radicals as well as the riboflavin radicals for the cross-linking. It is a possibility that we have been doing the process, but the riboflavin was not actually there in the right concentration. There was more of an oxygen radical. The riboflavin radical was less. So the oxygen radical alone is going to do more stress for the cornea rather than the cross-linking. Maybe it's just a hypothesis. Somehow the progressive thinning is continuing and we are not getting the actual effect of the cross-linking. So advancing age, we normally don't try to cross-link anyone above 35 or 40. But this is a classical example in which one eye I had cross-linked is good, happy, a little bit of scarring is there, but flattening, it has achieved the flattening, patient is having unaided good vision. The right eye was not cross-linked because of the advanced age, it is actually showing signs of progression, and there was no absolute risk factors which we normally look for. Another case, again, above age of 35, it is progressing. So everything in management of keratoconus is centered about the word progression, but actually speaking, we don't know how to define progression. In this, actually that ABCD classification, we have BCVA as one of the variable, but it is clearly shown that UCVA or BCVA is not required for documenting progression. That is another unanswered question. And mostly we look at the keratometry, and it's just one piece of the puzzle. Others like various Kmax, pachymetry, various indices, everything has been described, but none of them has been validated. So the global consensus, again, this is the one good paper which is talking about the consensus in various management keratoconus. They say consistent change in at least two of the following parameters. Still, they have written only the parameters, not about how much in how much period. Like one diopter in 1 year or nothing like that has been documented. And in this also they say that the BCVA is not a very good predictive factor. That means, in spite keratoconus, your vision may be unstable, it may be changing. Your vision may be stable, but it may be progressing. So it's totally unpredictable because the progression is not linear. It's not like happening every day in the same speed. And the progressing indices are also not validated. Sometimes we see only one eye progresses, and there are the various variables like pachymetry may be reducing, the keratometry may not be having same change in its value. Managing progression after crosslink is an absolutely difficult thing because it cannot be identified at all. Is this a post CXL progression? One eye, good flattening, happy patient. Other eye is actually worsening in the astigmatism after keratoconus. So I have done the C3R, I have induced more astigmatism into the patient. What good did I do to that patient? So how I can assess progression in a post CXL cornea? I cannot actually do it. It is probably remodeling of the corneal filaments, or it may be the effect of the RGP on the topography, or it can be actual failure or the progression, failure of the procedure or the progression. I am left with only one clinical sign to look for any signs of post C3R activity, that is demarcation line. So does this demarcation line actually show the effect of the C3R? It's no study actually proves it, that the demarcation line we have fine time. Yeah. So this doesn't actually tell us that directly that the mechanical properties or the stiffness is related to the demarcation line. So there comes a question of extent of cross-linking. What is the actual extent of cross-linking that is needed on that particular cornea to stop the progression of the cornea? This is not defined. So when you do various accelerated and other this and that, newer modalities of C3R, you don't know whether you are achieving the same extent of cross-linking that is actually needed. It is whether it is an all or none thing, or it is partial effect that's happening, or whatever it is. It has not been studied in vivo. We know accelerated protocol based on this Bunsen-Rusko law, but it's only for the photo damage or the photochemical reaction. But it's actually the cross-linkings happening in the same, following that law, it is again unanswered. The difference in the accelerated is that accelerated shows a very shallow demarcation line, which shows that it may not be as effective as a Dresden protocol. There are some studies shows that it's equally effective also. The difference here is the availability of oxygen, which was clearly demonstrated and clearly mentioned in Dr. Anita's previous talk. All these accelerated modalities, accelerated protocols have less oxygen availability because the time exposed is less, up to 9 minutes or 10 minutes or whatever it is. Sometimes we get unpredictable results like this. In the left side, you see the CXL was not done, it didn't progress, vision is maintained. The left side, aggressive CSR was done, CXL was done, it went into scarring, astigmatism, vision dropped, and unpredictable result. So it can induce scarring, it can increase astigmatism, it can cause more thinning, which are all undesirable effects of C3R. Why this is happening? Because the cross-linking which we say, it's not happening at the same level, same extent at all the levels. Some areas are more cross-linked, some areas are less cross-linked. So what we are actually creating a more irregular cornea. And this is not predictable. See, if you look at the top scan, the left, both are the eyes of the same patient, but in one eye we had a very good result, in other eye we have a bad result. We are actually creating more astigmatism in that. It is a remodeling of the collagen as an effect of the cross-linking, but an undesirable, unpredictable remodeling is happening there. So can we predict the remodeling? Customized CXL is one step towards that, where it's a cone-centered approach, or various fluents is used to treat the various areas of ectasia based upon the topography. Again, a very good thought, but we don't know whether it's going to help us or not. Again, combined procedures with corneal cross-linking and the PRK and all we are doing, it's basically to normalize the topography. To bring, you can see that the cone has been brought to the center and it's much more normalized. But again, here the predictability, the refractive stability, and as we discussed in the previous slide, long-term thinning. These are all unanswered questions and now not been studied properly. What if it actually fails? This is a case of actual failure of C3R. After C3R, it went into eye drops. But this is a case of Down syndrome, a child with aggressive rubbing. This is actually failure. We need not look for any investigation to see if it has failed or not. In such cases, we may have to go for surgical management. But in other cases where we suspect failure, there is always a repeat CXL opportunity. It is in literature. Once again, you can repeat based upon various variables like what we have discussed in the previous slides. Pregnancy has already been told. Only one question is, we tell the patient in pregnancy, it may increase. Okay, they are not going to change the plan of pregnancy anyway. It will happen. What are we going to do in addition to that patient? And during pregnancy, okay, we observe. And if it progresses, we again do C3R. So, is it actually risky to do C3R during pregnancy? It's not very documented. One report which I read was that why they don't do C3R is because it doesn't have any effect on the baby or the mother. Probably the results are little unpredictable because of the hormonal changes and the collagen loosening and all those things. Thing is, if it happens to have any complications, we may not be able to do further things for the patient. Unluckily, the patient happened to have a corneal infection, or if she happened to have a therapeutic keratoplasty, probably we may not be able to take up that patient for further treatment. So having that in mind, we tell them not to go for the C3R, and it's not due to any bad effects of the UV rays or anything on the mother or the baby. To summarize, I take this, I borrow this quote from one of the articles, which says that in seeking to determine whether a keratoconus patient is progressing, or remember that we are actually treating patients and not numbers. So what we need is a holistic evaluation that takes into account not just the numeric change in the imaging metrics, but also the patient's history, visual acuity, subjective complaints, corneal signs, is critical to determine whether progression has occurred or not, and is likely to occur in the near future. Because every patient of keratoconus is different, and it's very difficult, I think, in the near future to have a common guidelines to treat all the patients. Thank you very much.
Thank you, Dr. Sujit, for that excellent keynote. Actually, it was very thought-provoking, and I feel a little bit scary in the next days to deal with the keratoconus patients. Thank